Thanks, Rachel. Yes, I'm Andy McCann. I'm the lead data scientist with the nursing and urgent care team at Midlands and CSU, accompanied today by Kelly Bishop, who'll introduce herself, I'm sure, in a moment. And yeah, for those who weren't here at the very beginning, Rachel was just talking about Hacker 24 coming up, and I think there's a week or so left for people to submit expressions of interest that they want to present at the conference. So yeah, I think part of the motivation of having us here is to promote that a little bit. And from my point of view, yeah, I'd encourage any of you that are analysts have done a piece of work to present it. It's a very friendly conference. I think it's a bit different this year. Last year, one of the things was there was so much going on. It was split into quite a few different rooms, and so not everybody got to see everything, kind of thing. So yeah, we were hidden away a little bit in a room at the far end of the conference, but it went very well. I have to say, if you're nervous about showing your work, I was too. Needed quite a lot of encouragement to show this. Kelly in particular twisted my arm quite a bit. I think when we work on things, we often look at the outcomes and think, well, that's obvious, isn't it, in retrospect? And yet, unless you've gone through that process, it perhaps isn't. So yeah, I needed persuading to do this, and yet was surprised and very pleased about the feedback we got. Yeah, including Director of Operational Insight for Urgent and Emergency Care at NHSE loved it, and told Sarah Jane Marsh about it and got us to present it to an NHSE Lunch and Learn. So yeah, even though it didn't seem particularly data sciencey to me, and I thought, will people be interested? They certainly were. So I'm sure that if anybody else has got work there they're not sure about, seriously consider presenting it at Hacker 24.
Yeah, I would concur, obviously, and we had a huge range of contributions last year. We had and it did range from sort of more data sciencey focused, and we had a lot of qual analysis as well shared at the conference. So I think as long as the context is there, as long as you're able to describe what it is, what the question is that you're answering, and the potentially what the impact might be. We've had people feedback and say it was their first conference that they presented at, and they felt it was they were very encouraged and felt it was a very pleasant experience. And of course, for everybody who was there, it was just a great atmosphere. It was a great atmosphere, and it will be this year as well. So we're planning something really nice as well this year. But the main thing is that everybody, if you put an abstract in and you present, you get to be there as well. And yeah, I look forward to receiving lots of abstracts of representing people's work that they've been working on. Hopefully, this has encouraged people to submit an abstract. So thank you. Anyway, let's get on with your presentation.
Yeah. So as I say, this is a bit of a double act. I think one of the important things about this piece of work and what we wanted to emphasise at Hacker was how we're very fortunate in the CSU that we work very closely together. So the data scientists, me and my team, work very closely with clinicians like Kelly, and I think when that works well, it works extremely well. So yeah, I'll let Kelly introduce herself and also introduce the topic.
Well, thanks, Andy. So my name's Kelly Bishop. I'm Assistant Director of Nursing and Urgent Care in the Nursing and Urgent Care team. As Andy says, it's the relationship that brings this work together. It's bringing the data science and clinical together. So it's the so what that comes out of the data. It's really being able to map the data into sort of real, true clinical pathways. So hopefully this is what we'll be explaining in the presentation today, how that can come together. So this is a very high level overview, and then we'll get into a bit of what the programme was. This is a Northwest programme looking at the impact of COVID on the urgent care pathways, and it started off well, there's 25 sites in the Northwest hospital sites, so it's your type 1 A&E sites, just to give that context. And it started off with a real in-depth data analysis of all 25 sites. So massive amounts of data packs, and Andy and his team generated those and then worked with us, the clinical team, to really understand that data and develop the key lines of inquiry, what that data was asking, where it didn't make sense, where the patterns were changing. Then what we did is we took that knowledge of that data into the hospital sites physically. So we had conversations with the teams, but actually we walked the pathways. We spent time in the clinical areas. We spent time with the teams in each of these 25 sites, working through their whole urgent care pathways with that absolute data in our minds, trying to understand, okay, so actually how is this data working in the real day-to-day reality of this urgent care system. So we did 25 site visits, and then we wrote up 25 reports, and then we aggregated them. So we had one for each RCB in the Northwest. So we had an aggregated report for Lancashire, South Cumbria, one for Greater Manchester, one for Cheshire and Mersey. And that's like a thematic aggregation. And then we aggregated it up to Northwest regional level. So that's how it worked in kind of that pyramid effect. So that's the programme basically. So that's the introduction. So I'm going to hand over to Andy first. He's going to go through the walkthrough of the findings of the data, and I'll come back to you later.
Thanks, Kelly. So as Kelly said, we did very detailed site level packs, but we'll not try and go through those here. Instead, I'll just look at some of the very high level data findings that we presented at the end. So here's something, and although it's a Northwest study, this is England national data we're showing here. So putting this into context, when we started this project in early 2022, I think there's some discussion around it in late 21 and early 22, so quite a long time ago now. The narrative generally appeared to be just completely focusing on the negative aspects of COVID, as you'd imagine, and I absolutely do not want to minimise those. You know, the impacts of, we were all in different ways affected directly by COVID, and obviously the effects of it were dramatically negative in so many ways. But I think a lot of people were expecting also to see the same picture for urgent care, and there was talk about what caused hospitals to fall over due to COVID, and people were looking for a real sudden negative impact of COVID and how that immediately affected urgent care and the subsequent impact from that. However, when you look at the data of what actually happened, you realise that isn't what happened for urgent care, certainly for flow through the emergency department. So this chart showing a long-term trend of 4-hour performance. Now, we know 4-hour performance isn't a perfect measure of a flow through ED, but it's probably the best consistent long-term series we've got. And it's very clear that for a good decade before COVID, there was a really clear downward trend in 4-hour performance, superimposed with a pretty clear winter-summer seasonal pattern. Now, actually, the first year of COVID, counterintuitively, saw the best 4-hour performance that had been in 5 years. We're actually close to hitting the 95% target for the first time since 2015. And then during that first year, yes, performance worsened down to winter 2021. So obviously the seasonal pattern before COVID was quite different. So there are different reasons that it dipped here. We had the beginning of the second wave of COVID and so on, rather than the usual respiratory viruses we got in previous winters. So for different reasons it came down. But then performance recovered again in the early spring of 2021. And it wasn't until after this point, kind of April or so 21, that performance really dropped and then actually fell below this long-term trend that had existed beforehand. And this is about as far as the data went when we completed the study. But if we look at what happened after that, yeah, very poor performance in December 22. Quite a few things going on there. There was all the concerns over strep A. There was a very severe and early spike in flu, because all the measures that had suppressed COVID during this period for these past 2 winters, the social distancing, hand washing, all those kind of restrictions had also restricted the spread of normal seasonal respiratory conditions like flu and pneumonia and so on. So when they came back, we didn't have a lot of immunity, and they came back with a vengeance. So very poor performance then, and since then it has remained below this long-term trend. But what we think actually happened was that the things that caused this worsening here were already in place in this first year in COVID, but they were masked by reasons we'll look at. So again, this, when you look at it and you think, oh yeah, of course, is not a great surprise. But what happened at the onset of COVID? Attendances, ED attendances, roughly halved. We were all scared, didn't want to go to hospital. So attendances, the numbers coming through the front door dramatically came down. We think actually probably more importantly is the fact that bed occupancy fell so sharply. So bed occupancy in the northwest was up well over 90% in the winter before COVID, challenging finding beds for patients in ED who needed to be admitted. At the onset of COVID, that fell to around about 50%. And it took a long time before those numbers got back up to the levels they were pre-COVID. So for this whole year here, we had historically extremely low attendances and very low bed occupancy. So those things together greatly ease the flow through ED. And I think Kelly will corroborate that from the site visit, some of the comments that there were about how, yeah, despite all the other impacts of COVID, critical care and so on, the actual flow through ED was far easier than it had been in previous years. But as we say, we think during this period, these other pressures were emerging and they made themselves felt when attendances returned to normal, and particularly when bed occupancy returned closer to its pre-COVID levels. So here's one way we tried to look at what was happening, and I'll get a little bit ambitious here and try and flip from PowerPoint to an interactive slide if I can. So this is showing a concept we call congestion. It's nothing too clever. It's simply we're talking about the number of patients in a department at a point in time. So this is a particular ED department that was part of our study. So this idea of number of patients in the department, when you're actually in an ED, you'll probably see this. It's a measure usually written on the wall there to let patients know roughly how long they might be waiting, how busy the department is. It's a commonly quoted number there, but it's something that traditionally I don't think as analysts we've shown that often. We tend to look at attendances and so on, not so much this idea of how many people in the department at a point in time, because you've got to calculate it, I suppose. We do use it quite a bit more now. So, for instance, in the Lancashire and South Cumbria System Control Centre that we're involved in, we keep a very close eye on this idea of how many people are in the department compared with how many you would expect at that time of day, to understand emerging pressures and to look at things like perhaps ambulance diverts, and so to relieve pressure on one ED if it's a lot busier than another. But this is doing that on a historic basis. So we wanted to look at the period of late 2021, so September to December. So we've compared that with a similar period, September to December 2019, pre-COVID. So the bluey-green cyan lines here, this is each week in that period, late 2019, and how many people were in the department at any particular hour of the week. And then the thicker cyan line is the average of those. Similarly, the red lines are each week in late 2021 and the average of those. And so you can see that often, so if we look at, say, where are we here? A Thursday at 3 p.m. So the busiest Thursday at 3 p.m. in late 2019, this department had 84 patients in. And yet even in the quietest week in 2021, there were more patients. There were 85. And in the busiest week in late 2021, 139 patients in ED at 3 o'clock on a Thursday. So the difference between these two lines on average is 61%. So this department, and we see it was the case in almost all departments, was definitely busier in terms of how many people are there in the department at a point in time needing care. However, if you compare that with what had happened to attendances, it's quite interesting, because when people are talking about this, oh, we can't cope, we're busy, and they are busy, they were busier, they had a lot of patients to deal with. I think people tend to talk about that in imagining it's because of footfall, it's because of more people coming in. And yet, in fact, generally, that wasn't the case. And in fact, we picked an example here where the number of patients in department did increase. This is one of the biggest increases we saw, 10%. But as you can see, the arrivals per hour were in this department a little higher, but not very much higher than they were in that period in 2019. So there's far more of an increase in the number of patients in the department at a point in time than there was in attendances. And if we try and flip back to the slides and show that in all the other departments that we looked at, this is a comparison of the change in attendances versus the change in that idea of congestion for all the departments we looked at. And you can see, to fit it all on, we've had to change the scale. So this dotted line here is if congestion had increased in line with attendances, you'd expect to be on that dotted line. But in fact, in almost all cases, departments were far, far more congested. They'd increased their congestion far more than the attendances had increased. And there are a few exceptions down here, but I would note that all of these are quite unusual small departments. Some of them, in fact, were ones that were that closed overnight. So there wasn't the opportunity for this backlog to build up of patients in the department. But for the larger departments, generally, the issue seems to be less about the number of attendances increasing and more the fact that everyone that's in there is waiting longer. And instead of dealing with patients who've just arrived, you're dealing with patients who arrived hours ago or possibly even the previous day. Even cases, quite a lot of cases where the total number of attendances in late 2021 was actually lower than the number in late 2019, and yet these departments were still, 30–40% busier in terms of how many are in the department at a point in time. I think one thing that's important is probably how that built up. And again, I'll try and show this so I can hover over some of the numbers. So, as I said at the beginning, I think we were expecting perhaps to see there'd been a sudden impact of COVID that had a negative effect, and maybe there could be some sort of reset kind of event to get back to where we were before. But that isn't really how things developed. So for this example here, if we look at now, each of these points on this line is a week. So we've averaged the number of patients in the department across a week. So at this really quiet period at the onset of COVID, there's only about on average sort of 18, 19 people in the department at a point in time. And that number increased very slowly. This example department increased by kind of one patient a week is the only increase. It's very, very gradual. So when you're there in the department, you kind of hardly feel that happening at week to week. It's very gradual. And yet the effect of that one person a week over 18 months is that this department here, you get to there October 21, you've got an average 90 patients in the department. So one patient a week over 18 months means a department that's over 4, getting on for 5 times as congested as it was in this period. I think one thing that does make me wonder, and I know Kelly's got views on this as well, is was it important that rather than it being this sudden shock, there was this creeping normalisation of conditions in ED? I was struck by a visit we had to an emergency department. This wasn't actually part of this study, this was later, but one of our one ED I was in, where the patients that were being cared for on a corridor, each of the corridor spaces had a number so that the department could more easily track where patients were. And someone else on the visit was impressed by this and said, oh, isn't this good that they properly can track, where patients are and so on. And yes, it was better than other departments who maybe didn't have such a good handle on exactly where patients were because the corridor care was a bit more haphazard. But it struck me that that was a reflection of the fact that this caring for patients on corridor, waits of over 12 hours, which pre-COVID did happen, but was a rare and unusual event, has become just so normalised that we have to have systems to deal with it. And I wonder whether part of the issue with that is that it's happened gradually rather than as a sudden shock. So I'll hand to Kelly shortly, who can talk through more of the reasons why this has happened. But just looking at some of the things that the data shows pretty clearly, most of that increase in wait is for patients who've been waiting to be admitted. So two ways of looking at that. Here's the mean time in department for patients who are admitted. We don't have a very long series for this, but I think it's clear that, like for our performance, it will have had a seasonal aspect, so waits are longer in winter pre-COVID. But then after this point, we talk about kind of April 21 or so, the waits have increased and increased and increased from round about kind of 4 hours here from arriving in the department to leaving the department and getting into a bed, to more like 10 hours here in kind of spring 2022. And if we compare for each of the sites that we looked at, the increase in average time in department for those patients who were admitted versus the increase for those who were not admitted, who were sent home again, you can see that generally the increase is far greater for those that are admitted. So a busy department will clearly impact on the lower acuity patients who need care and then sent home, but it's generally far less, and it's generally for patients who are admitted, which naturally leads us to imagine that a large part of the problem is challenges in finding beds for those patients. So in turn then questions of why that would be. This is a chart showing inpatient now, not length of stay in the ED department, but length of stay in an inpatient bed, complicated by whether you include or exclude 0-day length of stay, SDEC, and so on. But either way you look at it, that there was this dramatic increase here, and that ties in quite nicely. There was a talk a month ago. Andrew Mooney, I think, from the Health Foundation, had done some quite interesting work on length of stay during the COVID period. Yeah, and his argument, I think, was that a lot of this was due to COVID, either directly patients who were admitted to be treated with COVID, or importantly those with COVID as a secondary infection, which led to challenges, particularly around the discharge and so on. So we think that's an issue. I think also there's a general acknowledgement that other discharge issues, I notice we've got quite a few local authority colleagues on the call today, I'll be feeling familiar with the challenges around discharge of complex patients, which will have almost certainly also contributed to this longer length of stay. So there's some of the high-level data findings, and if I'm pass back to Kelly for what this translated to on the ground with the observational visits.
Okay. Thank you, Andy. So Andy's just described congestion, and it's a really good way to look at things, congestion, in terms of how that A&E feels. It's a real good quality measure as well in terms of the quality of care you can deliver in the department. So really just focusing around, okay, so what are the reasons for the congestion that's built up? And what we kind of discovered looking at the data and then collaborating that with the site visits and the observations is a lot of factors changed during the pandemic. So in a way, from an emergency care point of view, the tap was turned off. I know that sounds bizarre because everybody talks about the pandemic as being sort of clearly this massive event in the healthcare world, and it certainly was for respiratory wards and ICUs and things like that. But if you talk to the A&E staff, they actually say that it was probably the easiest and beds were available, they could floor them, and it's a time that they've never experienced. But what happened, and this is why we call it the wheel of silent circumstances, things changed. So operating practices and clinical practices, whilst the tap was turned off, changed. And nobody could see it because the pressure wasn't there in that ED system to see the impact of those changes. But then, as the pandemic progressed and the healthcare system opened up again, that tap was turned back on. And these changes had happened that nobody realised. So once this tap had been turned back on and the demand of healthcare came through A&E again, then that's where the performance went, because suddenly all these silent circumstances had evolved. Nobody had seen it. The tap had turned back on and it was like, bang, performance goes, and there was difficulties in flow. So I'm just going to talk really high level through what these 7 circumstances are that really impacted on congestion. Thanks, Andy. So admitted weights, Andy's talked about with the data, we can clearly see that admitted weights went up post-pandemic, and that won't be news to anyone. But actually, when you walk in an emergency department, during the review, things will be slightly better now. Emergency departments have changed in the way that they now operate. Okay, so they're not running emergency departments anymore as the typical model of let's see them, send them to a ward bed, get them home. They've turned into medical assessment units within EDs now. So it's become normalised that patients that would normally be admitted to a medical assessment ward are kept in ED because there's flow, because we've just got used to different practices during the pandemic. It's normal now clinically for the acute physicians to say, oh, I'll see them and look after them in ED. Before COVID, they would have said, pull them up. That was normal practice. Now we're just used to that way of working. And many of the EDs we walked through, they are like higgledy-piggledy areas now. So you go in one room and it's like, you'd say, oh, who are these patients? Oh, well, these are medical patients. So the physicians are looking after them. So I'd ask the question, okay, so where are they in the data? Oh, no, they're still on the ED pathway. It's like, right, they're being looked after by the physicians. Yeah, but they're still in a room off ED. So we're keeping them on the ED pathway. So from a clinical perspective, they're treating them as an assessment inpatient. But from a data perspective, the clock's still ticking and they're non-admitted. So that's one reason, beyond the fact that actually, yeah, patients are waiting a lot longer for beds. That is undoubtedly there. But it's apples and pears reporting. You could walk into another ED in another hospital and say, well, what's this room full of patients in this ED? And they'll say, oh, these are all medical patients being looked after by the physician. Same answer. And then I'd ask the question, oh, how are you reporting them on your system? Oh, these are now 0-day length of stay, or these are admitted patients. So from an operational clinical perspective, exactly the same pathways. It's like that in terms of how they've chosen to put that in their books. So, you know, it's really complex data scenario of who on earth are you describing in the data, admitted and the non-admitted ED pathways. To really understand that. So that was the main thing really in understanding the admitted pathways. If you move on, please, Andy. So direct admission pathways. So another fascination, and I love this. This is probably one of my favourite graphs, is because it really tells a story. So you can see there when the pandemic hit and your direct admissions, it absolutely goes to 0, and that's fine because people were having to be screened for COVID. Everybody had to go through ED because we needed to make sure that people with COVID weren't being put everywhere, and all hospitals had this through ED policy so that everybody could be tested and are treated appropriately. But you can see from that graph there clearly that the direct admission pathways they've never really been turned back on again, gradually. So again, pre-COVID normalisation is go straight to ESTEC, go straight to MAU, surgical assessment, all those direct admission pathways that were beginning to work. Because we had to switch them off, they haven't turned on fully again. People have lost trust in them. The GPs have forgotten how to use them. And all that work needs resetting, like it's a whole new work stream again to set those direct admission pathways. But then ED is more congested because people are routing through ED rather than around ED. So massive piece of work to do on resetting direct admission pathways. Thanks, Andy. Demand is a fascinating one, and this is something that we struggle to capture in data in this programme. So this is something to really think about. So we can look at demand in terms of attendance, footfall, numbers. What we can't see through data easily is actually what is that demand in terms of the workload of the staff. So what's the acuity of the patients? So if you walk through EDs, it doesn't take a clinician to know that actually they're high acuity, high demand patients. So we walked through 25 A&E departments, and I was absolutely astounded by the types of patients. We were the old, frail, led on trolleys, you know, waiting 24 hours, even frailer by the time that they've waited 24 hours on trolley. These are not patients that you can flow in and out of ED. These are the type of patients that are now in ED. And acuity is fascinating, and it is something I really like to look at in terms of data, because I know from the Manchester triage score, when people are, you know, into their ED data, you can look at the acuity of patients that present in terms of the reporting. When I've had these conversations clinically, and also with people doing PhDs in this subject, have I frozen? My picture's frozen. Can you hear me? Yeah, okay, I'm back. I froze them. The actual recording of acuity, it's real. It's just not a scientific way. It's the clinical judgment at the front end is completely different. So it's not great to pull the acuity from the data from the perspective of the conversations I've had, but it is really, you know, the demand of EDs. So when we're talking that they're 60% busier in terms of more people, there's not just 60% more people, there's 60% more people that are really needing a lot of care. So that needs to be taken into consideration. Thanks, Andy. Next one. I won't go into this too much, but a biggie, obviously, pandemic, infection prevention and control. That really is complicated for ED and hospital flow, because you've got to get the patients to the right places. So not many hospitals, the older ones, they don't have side wards. They've got to turn the bays around. So if you're cohorting, and then you suddenly have male patients, when you've got female beds in bays where you're cohorting, you've got to clean, turn around. It takes such a long time, a lot of effort to do that stuff. And actually hospitals that have medical assessment units with multiple side wards performed a lot better than those that didn't have side wards. So there's definitely there something about future learning for the infrastructure in hospital buildings. And I know the new hospitals are now side ward based, which is helpful. But without a doubt, when there is complexity with infection prevention control, that absolutely impacts and slows through and increases congestion in EDs. Next slide, please, Andy. A quick note on paediatrics, just as well, for I think this is really applicable for people looking at this from a data perspective, is paediatrics felt completely ignored. We went through, talked to many paediatric clinicians through many paediatric departments, and actually all the guidance, everything around COVID was focused on the adult population. And just to really bring that home to the reality of the paediatric care, it's suddenly the toys were taken away, the playrooms were closed in hospitals because they couldn't, touch different toys, and the staff had to contain 2-year-olds into a bed space and just limit them to single toys at a time that needed to be cleaned. The bed spaces had to be certain 2 meters wide, but that guidance didn't allow for paediatric patients that needed a parent sleeping beside, and there was no guidance when those toys were allowed back in. So, just to give you some real world context of how paediatrics felt. So, I don't know how much data we've got on paediatrics, I suppose, but from an operational clinical point of view, it's something that was very, very lost in the pandemic times. Thanks, Andy. Length of stay, Andy's obviously talked about that through the data, and without doubt length of stay has gone up, and as we all know, I think largely, and we won't argue it, that is due to the fact that patients aren't leaving hospital because of the challenges in social care. There's a very high and increasing rate of patients that are not meeting the criteria to reside, and I think that is absolutely collaborated by all the site visits and the clinical viewpoint. So it's fewer admitting beds because if the patients are staying in the beds longer, then there's less beds to admit patients to, and it really is as simple as that. So there's really sort of no other argument that is the root of the cause. Thanks, Andy. We visited Nightingale facilities. I think just interesting, perhaps, if you're looking at additional beds in data to understand Nightingale facilities. They weren't great. They were very big open spaces, you can see there, big open roofs, which means you can put anyone with an infection in there because they weren't compliant with infection control. This particular facility I visited wasn't even fire reg compliant, so they had to have tens of marshals stood around in case that there's needed to be evacuation. So perhaps not for the data, but a lot of learning there for us to recommend in terms of, whilst we've got breathing space, and let's hope this never happens again, but let's take that opportunity to think about how we put additional beds into the system that are actually usable and safe for the system. Thanks, Andy. I think we're nearly there now, aren't we? So bed occupancy, Andy's talked about again. I think what's interesting with bed occupancy is, as you can see by that graph there, it was higher pre-COVID than it is post-COVID when we did this review. So if you talk to the hospital, well, there's so much pressure, the hospitals are full. Undoubtedly, the hospitals are full, but actually they're not as full as they were. And that's something that the clinical and the operational teams are like, no way. But the reality is no, they're not as full, but things are more complicated because I say patients need to be put inside rooms. You've got all that IPC, so it's actually they're not more full. It's just the beds are less available, and there's a definite different story there. So there's just understanding that nuance as well. And don't forget, with the G&A beds, that's called elective care as well. So elective care has taken a long while to get the theatres back and going. So they've not been using those elective care beds to full effect, so that's impacted on, and perhaps why they feel full, but they're not actually as full as they were. And the final bit is the ED environment. I already touched on it, but when we look at ED capacity and congestion, we're thinking that pre-COVID. So EDs have been bolted on and built on throughout COVID to make them bigger, to change the layout. So an ED that was designed for 50 patients pre-COVID might now comfortably take 70 patients. Yet we see that as congestion. It might be that actually that extra 20 patients, they've got extra space. So it's more that the EDs need resetting and agreeing what the coding is around that ED, like I alluded to at the start, around their different coding practices. So definitely a requirement there to just really reset what an ED is and how are we coding it, because every ED is so different and the way it's laid out. The rest of the slides I won't go through because conscious of time, I just want to make sure we hit the relevant points. But we did capture workforce feedback as well. It's important to bring the feel and experience of the workforce. Just one I want to point out here in terms of learning that we found through the visits is this second red down. Staff request that trusts never stop visiting practices, again for those receiving end of life care, and allow staff to risk assess it individually with the patients. If all staff was basically, they was raw to say, never ever do that to us again. Never make me not allow a relative into a dying patient. That was so raw as you spoke to the staff. That's the one plea. When I said, what can I tell the policymakers, it was never ever ask us to do that again. So some really powerful messages coming through the staff that I don't want to lose sight of, hence just bringing into this study. And the rest are recommendations. I've kind of gone through the recommendations, but they're in the slide pack if anyone does want to see them, that can be circulated, but I've talked through them as I've been presenting. So yeah, that concludes really. And I think, just to, as we started off, is for us, it's that collaboration of data science and clinical that we're really passionate about. It's being able to really pull those two expertise and lenses together to make the difference and add the value. And Andy and I work exceptionally close and exceptionally well together on a number of programs, as I do with other members of the BI team as well. So absolutely, that's what we're about in the team. So yeah, thank you. I'll stop. I don't know if Andy wants to add anything more, pause for questions or summary up. Thank you.
So if Andy doesn't want to add anything, I just want to say thanks very much for that. That's both of you. That's really, really interesting and a great walk through your work. I think there's a lot of it will resonate with other people who are here in the audience. There's so many different things to learn from it, and it's, as with everything, it's like, well, what next? What can be done using using the information that you've gleaned, using the evidence that you've pulled together, and the stark differences sort of before COVID and after COVID. For example, the way people are admitting into hospital, and they're not doing it right, are they, Kelly? They should go, but they were doing so well.
They were.
You know, did all that work to get to these different routes in to make it more efficient and the flow be better. It's all about the flow. It's all about the flow. Yeah, that's very interesting, and I'm really really taken by that, the strength in that. The relationship between the analysts, the analytical side of this, and as clinicians as well, because for so many reasons, but just so Andy and team getting to know that the subject area so well, and then people like you, Kelly, and working with people on site to really bring that intelligence, that information to life, and just making it real for everybody as well. It's something that we've talked about so many times, about that those key relationships between an analyst and the subject area, the subject specialists, the people who actually live and breathe the services, and so on. And it's so important, and it just means interpretation when you add that triangulation in, that feedback, that those insights from people on the ground, just people who are doing it. It just instead of us as analysts just wondering, we can actually get some of the answers. You know, it just makes it so much more concrete. We did have Jacqueline said in the comments about wondering whether that acuity of those ED patients, those very old, very frail people who were there, and as you could see, it was a visual. You didn't, the data isn't there to describe them properly, but you can, and you know, I've been in ED departments myself, and it's very clear what the proportion are who fall into that category. Is any of that a response to there being sort of pressures in primary care and not being able to be seen in other areas, or is it in fact just a genuine response to there being those clinical needs for those patients? It's usually a combination, isn't it? But and I'm not saying you know all the answers, but I think it's interesting to take some of, you know, what can be learned. Are they in the best place for them? Should they have been there, etc.
Yeah, multiple stories as always, isn't there? But I know when we went to the surgical wards, they would say that they had patients presenting with late stage cancer. They'd not seen that pre-COVID, just because they'd not had the access to primary care during COVID. So there is definitely that people have access to primary care for more preventative health during COVID. So they are presenting more acutely unwell. But it's not that they're ill. The other complication is not ill with one thing. So these elderly patients, they're not acutely ill with X, Y, or Z. They're just a little bit ill with lots of things. So aging population as well. It's difficult. And
then there is sorry, Andy, the like you mentioned in your presentation, if somebody comes into hospital for whatever reason, so I've had first-hand or second-hand experience of this with my father over the last year. As soon as you enter that environment, the deterioration is rapid. Absolutely rapid. 24 hours in hospital is the equivalent of somewhere else, and so just that huge emphasis on just sort of getting that person not there, basically, was pretty much my angle. But yeah, Andy, were you going to come in there?
Kind of that point, really. Yeah, I was struck by Kelly saying to me before about how the needs in ED and on a ward are different, you know, and essentially they're trained for people. So whereas, as Kelly was saying, the ED has traditionally been, okay, see people quickly, get them into the ward setting. if you're then having to, ED staff are having to just care for the general needs of patients that may not even be related to the condition. I think that's where the deconditioning happens then in ED. So yeah, it's this vicious circle of people not getting the care due to COVID that they previously would have done early enough, the preventative care, and then when they're in there, potentially deconditioning even more.
Yeah, absolutely. I mean, so my father had a heart attack. It was a long story. Quite interesting from my interaction with care services point of view, and I was a nightmare carer for clinicians. I apologise to all of those people. I was polite, I like to think, but why is my dad just lying there? Why isn't he moving around? He's a very mobile person. Why is he just lying there? Move him. No. But I like to think I was firm but very fair. And he's all right now. He's fine. Yes, well, I would just like to say thank you again. I do find it fascinating. Not only, but the whole subject is fascinating, and there are so many different lenses. There's so many, and I love how you went, Kelly, to these sites and talk to people. It's so valuable. You get so much more information. I'm not saying, Andy, I'm not belittling your work. It was all right. You know,
we take Andy with us sometimes.
You did quite well, Andy. Well done.
It's always great when we can get analysts on site. I think that's a really good thing. We do like to do that because Andy, we try and get Andy on site, dust him off occasionally and bring him out, and that's, he sounds like
I present to you, this is an analyst. This is what they look like.
As you say, Rachel, yeah, you look at the numbers that tell you one story, but it's far from the whole picture. So yeah, it's crucial to see that in context and what it means in the real world.
Yeah, and I think all analysts should as well. Just to get that insight. So I don't mean go into ED departments, but it's just whatever the subject matter is, it's just if you know more about it and you can connect with the people who the subject specialist or the people who are passionate or both about these, and then it can just really add to your own understanding and in the way that you interact with that data and believe or not, maybe not believe the data someday, but it can build a whole lot of caution, sensible caution to some of the data as well. I've put on that because I've got less than a minute now. I do believe, so I will thank you again. But I have put the follow-up question on Menti, which is anybody left? People are still here, so there are people here. So if people would like to go to Menti, and we asked at the beginning whether you'd like to hear more about the data analysis or the observational side of this work. Most people said both, and so I'm just inviting you to now say, would you in the end, which aspects of the presentation did you find more interesting? Was it, in fact, the data analysis? Is that why you're here? Or did you think Kelly was quite interesting as well?
Not a competition, is it? Yeah,
there's no competition. No, so people aren't saying anything. So
I've got the question. The question isn't coming up for me on Menti. So.
Oh, well, that's a bit strange, isn't it? Let me try again. Oh, here we go. I think it's maybe it's coming up now.
Andy, you can't vote for yourself. That's not fair.
Well, you can as well. I'm gonna vote for Colin. No. Well, I'll put it. It doesn't matter. I know what people will say. I am 100% convinced people will have found the holistic experience. There we go. Much more useful, relevant, and it's the whole story, isn't it? We want to know what the story is to make it relevant to us as analysts and that topic. So people are coming in with both. I reassured. It's a lovely pink. It's much like my top, actually. So there wasn't any attempt to influence the results there. And I'll just move on just very briefly just to say. We got all sorts of exciting things happening in huddles, up and coming huddles, and what I keep saying it. I'm going to be a little bit more proactive about that. I know what they are. I'm going to put them on the website so people can see what they are as well. So that's only right. It's only good. It's only right, and I'd like to people should be more informed. In terms of the training and up and coming training for the end of the year, we've got spaces, in fact. Just please note this. So you don't have to be an analyst for this one. So it could be you, your colleagues, or it could be both. So this is Fraser Batty's Introduction to Decision Quality. Now that's in Birmingham at this studio, 5 minutes from the train station. I know it doesn't suit everybody if you're out there in the East Midlands, but highly recommend that training. And there are spaces, and it is first come, first served, and the lunch is very, very, very good. And you get snacks all day, and you get all sorts of things. But I do highly recommend it. It gets excellent reviews for that. So please do sort of take note of that. So back to my people. Thank you very much, Kelly. Thank you very much, Andy. I do hope you can come back one day. I've been really enjoying today's session, and thank you everyone for coming. See you in 2 weeks.
Thanks everyone. Thanks.